So I just wanted to introduce our speakers. We've got 3 speakers today. Liz Doherty started her nursing career at Providence, working on medicine in 2005. If I can just ask everyone to please mute themselves on Zoom. Thank you. She then moved to Ontario, where she completed her master's and her PhD in nursing, and then came back to Vancouver to work at Providence in 2015. She initially worked on surgery and then transitioned to working in urban health and caring for people with who use substances and or have substance use disorder. She's worked in multiple roles as a clinical nurse, a CNL, and a clinical educator, and she's now the clinical nurse specialist for substance use at PHC. This is Liz here. Naomi is our second speaker. She came into nursing with a background in community development and social justice. She's worked on the urban health medical unit and at the Rapid Access Addiction Clinic, and she's currently the nurse educator for substance use urban health, HIV, and the substance use program. And Brian, who's here with us as well, he works at the Rapid Access Addiction Clinic as a peer navigator since 2021, and he has lived experience at St. Paul's Hospital that he's going to share with us today. So I'll hand it over to our speakers. Thank you.
Thanks. So thanks everyone for coming today. So I am Liz. Thanks for that introduction, Karen. And yeah, we're just so grateful to be here and truly humbled to be presenting this session today on caring for people who use drugs. Next slide.
And to start us off in a good way, I want to acknowledge that we are on the unceded and traditional territories of the Coast Salish people, which includes the Musqueam, Squamish, and Tsleil-Waututh nations. And I think it's always important to extend this acknowledgement to something concrete. And I hope that this image is of our Indigenous Wellness and Reconciliation Team's action plan for Providence Healthcare. You can find this on PHC Connect. I encourage everyone to take a look at that. It has 5-year goals for Providence as far as what actions to be taken towards truth and reconciliation, and also goals for 2022. So I think it's really important for anyone who works at Providence to have a look through that and see how you personally can, or your work unit areas can contribute to action towards truth and reconciliation at Providence.
So we're gonna be talking about how common and prevalent substance use and substance use disorders are, as well as touch on and give some context on the overdose crisis, or as we more appropriately refer to it as the drug poisoning crisis. That is what is happening. And in the second half of the session, we'll talk about how we can engage patients and some resources that are available at PHC. And then Brian, our peer navigator, is going to share some of his personal experiences accessing healthcare here at St. Paul's Hospital.
So we do start out with a quick little Menti question, just around kind of gauging people's comfort levels in working with patients or clients who have a substance use disorder. So just kind of curious, and it's anonymous. I don't know. Maybe everybody knows that about Menti. We can't tell who says what. Just give a minute for folks both here and online. Come on in. Andrea. That's awesome. Well, I'm that's fantastic. Really interesting, and we're so grateful that so many people are interested in this topic, and hopefully it will come across that we're very passionate and excited to be here talking to you. All right, we'll just click over here. So the percentage of Canadians who develop substance use disorder is quite significant. At this baseline, that tells us that no matter what area of healthcare we're working in, that we're going to be working with people who have a substance use disorder. And we know that substance use disorders impact people across all aspects of life, across all socioeconomic stratas, backgrounds, ages, but we also know that substance use disorders are entwined with compounding issues around the social determinants of health. And I like this image because I think that it conveys this idea that we rarely see substance use disorders, certainly severe substance use disorders, outside of the social determinants of health. And we know that there are risk factors that increase the likelihood of developing substance use disorders, for example, childhood trauma, and that we really are seeing an acute complexity, especially when we're talking about the folks that we're working with in acute care settings. And so people have fallen through numerous cracks, exposing these deficiencies in our healthcare system. People who have experienced multiple layers of oppression, the unjust and racially charged impact of prohibition, the impact of poverty, trauma, intergenerational trauma, attempted genocide, houselessness, brain injury, mental illness. Many people we've worked with have all of these pieces as part of their medical picture. So one of the kind of possibly most challenging aspects actually of working with people with substance use disorder is a lack of suitable resources. For example, this comes up for us often is when we're talking about working with patients who have concurrent mental illness, substance use disorder, and an acute medical condition. We don't have a unit for that. So so we need to acknowledge where that challenge is actually coming from, is a lack of resources, yeah. I need to revert back to my clicker.
So in terms of Providence Healthcare, so we continue to see an increasing and really unprecedented demand for substance use services at Providence Healthcare. So for example, 1 in every 4 patients admitted to St. Paul's Hospital meets the criteria for substance use disorder and is followed by our addiction medicine consult team, who you'll also hear us refer to as our AMCT. As well, between the end of November, so November 2019 and March of 2022, our AMCT team completed 10,443 consults, which works out to about 12 new consults per day, and a 226% increase in referrals over the last 2 years. So quite significant. Also at our Rapid Access Addiction Clinic that we also call the RAC, so that's an outpatient clinic here at St. Paul's, which opened in 2016 as a result of the public health emergency that was declared due to overdose deaths. We're seeing at the RAC about 30 to 4 new intakes per week, and we have about 2,400 active clients at the RAC. And so for those of you who don't know, our RAC, it's a rapid access addiction clinic, and anyone can self-refer or they get referred, they can walk in. It's open every day of the year, and there's access to addiction medicine physicians, social workers, peer navigators. And so that's a service that we've been offering here at PHC in the outpatient setting.
So when we talk about stigma, we often think about words that we're using or kind of derogatory language or even just the body language. But one of the most, I think, kind of concerning forms of stigma is a lack of information and education and that absence of action. And so I was curious about this idea that we often talk about, and I looked up how the percentage of Canadians who develop diabetes in their lifetime, which there's varying statistics, say 8 to 9%. And I just, when I think about how much I've learned about diabetes in nursing school, the mechanics of the disease, the prevalence, risk factors, prevention, treatment, medications, and I think even in the sort of non-medical population, people are quite familiar. And then compare that to the education and information that we receive about patients with substance use disorders, and then looking at the difference, it's almost, it's close to 3 times the amount of people that have that condition.
So I'm going to talk specifically about some information, and a lot of the examples we give are based on inpatients or in hospital, but a lot of the general concepts can be applied across care settings. So further to what Naomi just said, most healthcare providers working in hospital do encounter patients with substance use disorders, but few have adequate training. Although we are doing more and more education here at Providence Healthcare, it isn't mandatory. And people also report challenges addressing people's substance use related concerns alongside their medical concerns or why they're here in hospital. And this issue actually led to the development of our addiction medicine consult team. So patients were coming in, maybe admitted to medicine. They couldn't treat their medical illness because they were having such issues trying to get their pain and withdrawal and their cravings under control. And so that led to the development of our AMCT. And I'll talk a little bit more about what our team looks like. But this isn't so at many hospitals. Many hospitals don't have addiction specialists. So we're super lucky to have our team here at both of our acute care sites, as well as our rapid access addiction clinic. And this knowledge and training is further compounded by negative attitudes towards people who use drugs. People frequently describe experiencing stigma and discrimination, and that their symptoms of pain or withdrawal are ignored or undertreated. And in fact, research shows that in acute care, we are actually typically undertreating patients' cravings and withdrawal and pain. And then also what complicates things is that abstinence is generally expected as a condition to receiving care. And these expectations can lead to conflicts between patients and staff. And so as a result, people who use drugs or alcohol and staff who care for them may face increased risks associated with patients attempting to hide or conceal their substance use. So, patients, for example, may leave the unit and return intoxicated. Perhaps, they're hiding their substance use. They have an unwitnessed overdose in the bathroom, or they're rushing to inject so people don't see and say they missed the vein and get an infection. So it can be quite risky. And as Naomi highlighted, our acute care system is not designed or well equipped to address all of these psychosocial factors that contribute to people's substance use disorders. So I'm going to just present a couple of slides with some questions. And there's a really great document on CRISM about how people who use substances are treated and engaged in acute care. And so I find these things kind of interesting to think about. So why can't they just stop using? And why should we treat someone who has caused harm to themselves? It isn't really possible to develop any kind of fair or consistent criteria for who deserves care. We care for people who get COVID and were unvaxxed, right? And so I often try and think about, our response in terms of, compared to our response to COVID, for example. There are also many reasons why people use drugs. Naomi kind of highlighted some of those, but usually trauma, mental health conditions, poverty, homelessness, and actually substance use. There's a peer that I work with who says, that's actually a reasonable response to underlying pain and trauma. We also can't expect people to have a goal of abstinence if they have no stability for their basic needs. So I'm talking about housing, food security, safety, connection. Oftentimes people are using substances to meet some of these needs. For example, people who are homeless may use stimulants at night so they can stay awake, so they don't get assaulted or robbed. So that's why you'll sometimes see people sleeping on the street during the day. It's safer, there's people around. So they're actually using to cope with some, things happening in their life. Cravings also can be quite overwhelming for people and can eliminate or restrict their ability to choose to stop using. It's also a common misconception that if someone's using substances, say they are homeless, they're doing whatever they need to do to support their use, their life is chaotic, it must mean they want to stop using. But that's not always okay, and that's not always the case. Sometimes people are using this as a coping strategy that works for them. So not everyone's goal is going to be abstinence, and that's okay. But we can offer care here to keep people safe and comfortable while they're accessing healthcare. So one of the ways we can do that is by treating their withdrawal so they could potentially reduce their non-prescribed substance use. And there's also a peer that we work with who reminded me that we need to remember to keep our expectations and our goals off of the client. It's really easy to know what someone else should do with their life and what we think they should do, but that doesn't matter. When we're with people, it's about them. And if they don't have any goals related to their substance use at this time, that's okay. If and when they're ready, we can offer that. And maybe we can support them to perhaps use more safely, reduce their use, whatever their goals are around their substance use. We often get asked, why don't we force patients to stop using substances while they're in hospital? To insist that a person stop using while they're suffering from, a life-threatening or acute illness is a significant barrier to care. Many people with substance use disorders, they will present here with life-threatening illnesses, perhaps secondary to their substance use. So endocarditis, heart infection, spinal abscesses, liver failures. But they also come in with medical needs unrelated to their substance use. In either case, the person needs to recover from this life-threatening illness before they can deal with all these physical and psychosocial drivers of their substance use. And so when we use a harm reduction approach, it allows us to focus first on the acute recovery. It's also important to note that unlike at the RAC, where people are coming in, they're seeking help specifically for their substance use, people who come into hospital with their medical needs may not be interested in receiving treatment for their substance use while they're here. They might simply want treatment for their medical issue. So in order to, it's our role to keep them safe and comfortable, but we're not here to push recovery on people if that's not their goal, or give input on their substance use in general. And if we can focus on addressing some of the harms of substance use without trying to force a change, people will be more likely to trust us and willing to continue with treatment. It's really important to note that when people access our services, if they have negative experience, that will affect whether they will come and access care here again. I can't tell you how many people or cases I've heard of where people will wait till they're super sick before they come access care because they're afraid of how they will be treated and what experience they will have. And yeah, next slide. Clients who use drugs are a danger to staff and other clients. Overall, we have a duty to prevent harm to staff and other patients, but a harm reduction approach, believe it or not, can actually improve patient and staff safety. So an example would be providing people with sterile supplies to people who inject substances, for example. That will prevent them from having to hide or reuse their equipment. If we give people sharps containers, that will prevent unsafe disposal of sharps and perhaps prevent needle stick injuries to staff or other clients. But what I want to say is that harm reduction does not mean anything goes in terms of unsafe behaviors. It's actually important to set boundaries if someone's behavior is potentially unsafe for them or others. And that starts with an honest, open conversation with people about, any expectations. It also includes asking them how we can support them to engage in more safe behaviors. We oftentimes find that when we get engaged to develop a care plan, that a conversation just hasn't even been had with the client. So it's really starts with the conversation. And we'll talk a bit more later about how you can have these conversations with people who use substances, for example.
I really like this quote by Dr. Bonnie Henry, and I think we can, I personally feel quite, proud to be a part of how we responded as a province to the COVID pandemic, and how much risk we were able to mitigate for people. But it has drawn this really direct parallel to our ongoing drug poisoning crisis, and kind of poses that comparison to say, like, why are we treating this so differently? So I'm sure you guys are very well aware. This was declared in 2016, this overdose pandemic. And since that time, we've lost over 10,000 British Columbians alone. So average about 6.5 people in British Columbia per day. And since even I started this job, I've had to change this slide multiple times to increase that daily number. It's the leading cause of death for men 18 to 39. And when we really consider that like lost years, when we're losing so many young people, and as I've mentioned, we know that people who are experiencing kind of intersectional oppression, certainly this is highlighted in our Indigenous peoples in British Columbia who are at such higher risk of an overdose death. And not necessarily because there's a higher prevalence of use, but less resources and accessibility. And the experiences of racism, like Liz said, is preventing people from having equitable access to healthcare. This is a question that obviously I think is on a lot of people's minds, like how can it's definitely not getting better. It's actually getting worse every single month. We get the coroner's report with, oh, this is a new record, 2022 setting new records. And there's a few things that I think are important to note. One is that across the board, the law of prohibition is always going to mean an increase in concentration. So when something is illegal, people are going to find ways to make transportation easier and detection harder. And we saw that during, the time of when we had alcohol prohibition, that actually prior to alcohol prohibition, the most common alcohol that was consumed was beer, very low concentration. And then during prohibition, that's where we saw this huge production of moonshine, which was, an alcohol that killed people and caused a lot of damage, and was one of the reasons why they stopped doing that. And we've seen this increase in concentration also from opium to heroin, from heroin to fentanyl, from fentanyl to carfentanil. And right, you can transport a very significant amount of fentanyl in an envelope the size of a greeting card. So it's always going to continue in that manner. And with the COVID restrictions, we saw the effect of that unregulated supply exacerbated by restrictions on borders, resulting in a really increase in that volatility and toxicity of the drug supply. So someone getting substances from an unregulated supply means there's no way of them knowing the concentration of what they're about to use. The more recent statistics are telling us also that we have this changes a lot because it's hard to get the testing accurate, but for the contamination of our street supply with benzodiazepines, in particular atazolam, which is really further compounding the risk for an overdose death. And one of the pieces I think is also important, as we saw overdose deaths started to actually decline a little bit in 2019 and then spiked again as soon as the COVID restrictions hit, that we saw this huge reduction in services and this increase in stress. And across Canada, we've seen that people, do end up using more substances. Alcohol has actually had a huge spike in consumption since the beginning of the pandemic. And we know that in particular for the street supply of drugs, isolation, using alone, is the #1 risk factor for dying of an overdose death. And so when we think about how much more people are isolated right now, and also just to kind of always tie back to like these services and what we're talking about when we're talking about lack of access and resources, is smoking is actually the #1 consumption mode tied to BC overdose deaths. And currently, of all the overdose prevention sites that exist in the province, there are 2 that accommodate people inhaling the substances. So I think that's something that often people don't realize, that there's that big difference.
So I'm going to talk about how we can engage and support people who use drugs at PHC and some of the many, many resources that we have available. This is just going to be a quick snapshot. There's a lot that we do and a lot that we provide, but we thought we'd start with some basic things. But we could probably do a talk for a whole day on this.
Yeah. So Liz mentioned harm reduction, and I think we often think about that like specifically around the sterile supplies as like that's harm reduction. But the reality is harm reduction is like a philosophy of care. It's a spectrum, and it's evidence-based. This is a scientific methodology, and it's a move away from the sort of unilateral focus and quite a moralistic focus on the substance itself, and then looking to how can we focus on preventable harms. And at Providence Healthcare, we have a philosophy of care for people who use substances that says, like, instead of requiring that people stop using in order to be able to access our services, that we can offer care options that meet people where they're at. And that means that we can have conversations with people about substance use, and that it could not be more important than right now, given the drug poisoning crisis. As Liz mentioned, kind of expecting or demanding abstinence is, there's no evidence that supports this idea of cold turkey. It's very unethical and not evidence-based to expect or demand abstinence from people. And we know that the most effective way is using that harm reduction approach, and in particular around withdrawal. We can treat withdrawal to allow someone a smooth transition to abstinence. And we do that, and we can do that really well. We can also treat withdrawal to stabilize someone on a long-term opiate agonist therapy. And we can also treat withdrawal to prevent someone from having to access the poison drug supply. And so I always like to say, like, when we're treating withdrawal, where we're treating cravings, this is a life-saving intervention every single time. Anytime we are preventing someone from having to use the poison drug supply or reducing their need, then we are that can be a life-saving intervention. We have here at St. Paul's Hospital one of the only safe consumption sites in hospital in Canada, and this service is open every day of the year from 10 a.m. till 8 p.m. And this is a place where people can go if they want to use via the route of injection, and can be supervised and treated if an overdose does happen. But this place also provides information and education around safer use techniques. It does have all the sterile supplies for any mode of consumption, and offers education and supplies for people who might be using through their IV lines, their peripheral IV lines, or their PICC lines. And they also provide take-home naloxone training and kits. And the Vancouver Coastal Health map just shows other OPS sites in Vancouver. And one thing I always point out, particularly for those of us that are in acute care, is, you know, if your site doesn't have an OPS, or maybe the OPS is closed, you know, for us to suggest them going to another OPS is not a feasible option. Like, we're asking people to travel a very long way while they're admitted for an acute medical reason. And what are they going to walk there in a wheelchair? But and then we have to consider, if people are leaving the unit to use, are they going to get penalized because they're not back in 6 hours? And then I think that's particularly relevant considering the benzo contamination and what the level of sedation that causes, and how long people can be knocked out unintentionally. Let's go from here. So one of the things that's come up a lot, say when I go over to MSJ, is the moral distress, that kind of conundrum that a lot of healthcare providers feel that they're in, to say, you know, you can't use here, there's no OPS nearby, I feel like I have nothing to offer you, and this is a horrible situation. So we created this postcard to try to kind of prompt some of the things that we think are super, well, I guess they're not all really simple, but things that can be done, and the top part kind of being from the healthcare provider. Obviously, we're nurses. We have a nursing bent on all our presentation, but I mean, I think that could be, lots of those points can be offered by anybody. Always, we want to be making sure that we're talking to people, ensuring that whatever care plan we have, whatever kind of plan there is, that we can optimize that. And then talking to the patient or client about things that they can do to keep themselves safe in this very unsafe time. So this is a resource that we're developing just because of that need, and we're hearing a lot of distress from people. Sterile supplies are part of harm reduction, and we have lots of sites across all of Providence Healthcare that provide these freely. And I always like to say, this is a very simple intervention that has like a myriad of positive outcomes. Like, we know that it reduces the transmission of bloodborne infections. We know that it decreases infections like what Liz was talking about. And we know that it actually engages people further in healthcare. But again, if we're handing out harm reduction of those sterile supplies and we see them, we can't penalize people for having them out. And we do see that can sometimes, when people see that at the bedside or in someone's bag, it sort of gets their back up and they kind of freaked out about it, and then it's kind of like cancels out the benefit. So we have to normalize handing these out, normalize seeing them. And then to me, that's always going to be, it's a bit of a flag for me to say, like, hey, how's it going? How are your scheduled meds working for you? Are you getting enough PRNs? Are they working for you? If I'm giving someone injection supplies, I'm going to make sure they have a sharps container in their room within arm's reach, and just check in about, like, what more could we be doing for you? What's going on?
At PHC, take-home naloxone kits are widely available, and many of our in both our inpatient settings and in many outpatient settings. And for those of you who don't know, naloxone, or Narcan, is a medication that rapidly reverses an opioid overdose. So in general orientation at PHC, all nurses are trained in how to educate and dispense kits to patients or their family members. There is a nursing protocol for this on SHOP, for those of you who know SHOP. But for anybody who is interested in getting training, there's lots of online resources. There's actually the government, or the Ministry of Mental Health and Addictions, has a naloxone training online module. The website is listed there. It takes about 10 minutes. You can learn how to recognize the signs of an overdose and administer naloxone. Toward the Heart is also a great website. But if you do the Ministry of Mental Health one, it'll allow you, once you complete the 10-minute training, it'll give you a certificate that can either be on your phone or printed out. You can walk into a pharmacy and get a take-home naloxone kit, as overdoses can happen anywhere, at a community event, maybe people are at a party. I can't tell you how many times myself or my colleagues, physicians, nurses, social workers, have reversed overdoses on our way to and from work. Frequently outside the hospital. And also kudos to security. We've trained security at both of our acute care sites to administer naloxone, as they often run into patients in the non-clinical areas like bathrooms or on the grounds outside. And they've actually reversed 22 overdoses since we started the program in the last year. And they were so willing to take it on and just like go above and beyond. So that's been another cool thing that we've been able to do here.
So we really see trauma and violence-informed care as part of this engagement strategy. This is a trauma and violence-informed care as a practice of integrating an understanding of trauma into all levels of care. So that's taking into account like the prevalence of trauma, the effects of trauma, and how our systems themselves create and perpetuate violence for people. And the research tells us that over 3/4 of Canadians have experienced some form of trauma themselves, and we know that it can have lasting emotional and physiological effects. And we also know the majority of people in mental health and substance use services also have a history of trauma. So we really see this as an essential tool, regardless of what area of medicine that you're working in, and that this is an approach and a practice that not only produces better health outcomes for patients, but is also shown to increase staff satisfaction and safety. We recommend currently what Providence is offering is the Safe Care workshop, which is online via Learning Hub. And the Equip Healthcare is, you can access, they have online resources that are free and that we can recommend certainly. There's lots out there and hopefully we'll see more and more of that at Providence.
And it's actually us that's doing this safe care education right now. It used to be our director of urban health had some special training in trauma and violence informed care, but he's been off. So we are providing this education in the interim. Nothing is posted yet for a date in November on Learning Hub, but it will be soon. So keep your eyes open for that, and we would love to have people attend. So with stigma being one of the biggest barriers to treatment and recovery for people with substance use disorders today, language really matters. And often the language that we use contributes to that stigma. There are a lot of stigmatizing words that are common in our day-to-day language. And this just highlights some of them. So, instead of calling someone an addict, this is a person with a substance use disorder. To suggest somebody or call somebody clean because they're not using substances does not mean they're dirty when they're using substances. So we need to be careful with our words. And if we use these words sort of inappropriately to describe people who use drugs, it can negatively impact people's perceptions of the disease and also other healthcare providers. And it perpetuates that stigma. And so if we can choose alternate language, we can help break down some of these negative stereotypes associated with people who use substances. And in the same way, the way that we chart can also have negative impacts and in fact, long-term effects on the care that people receive when they're accessing healthcare. So what we write in a patient's chart, it actually can affect the care that they receive for years and years. So this is an example from one person's chart. So I just filtered the nursing notes, for example, and this is what came up. So drug paraphernalia was the title of the note, but we could refer to that as safer use supplies or harm reduction supplies instead. Drug paraphernalia can have a negative context. I also click on a note that says behavior, and it's pretty mundane actually. Awake most of the night, compliant with care, want to see a social worker, no other concerns. I don't know if that's the same thing I would be documenting if it was, my grandmother accessing care and it was my shift report. I don't know if I'd necessarily title it behavior. So it's just to just be mindful of this. And we also need to review certain alerts that might get put on people's charts, like in regards to unsafe sharps or violence, for example. I certainly know colleagues who, perhaps are now in recovery, but still have these alerts on their chart for experiences that they had, years in the past. And so it can kind of, how we give report or how we document can get, someone's back up when they're, walking into an interaction with someone. So we just need to be mindful of that. And also, I'm sure you're all aware, but just to remember that patients and clients can hear us when we're giving report at the nursing station, and they can hear us when we're, behind the desk at the clinic. So we just need to be really mindful of the language that we're using and what we're writing.
So we're often talking about really complex cases when we're talking about working with patients who have substance use disorder, as I kind of alluded in the beginning. And what we find often is a very useful tool is a nursing care plan. And that's not just specific to nurses, because we think that at its best form is going to be really an interdisciplinary approach. And in particular, reminding ourselves to include community when we're talking about interdisciplinary approach, because oftentimes our community partners have so much collateral information and have a much closer relationship. So always ensuring that we do that. And then I think, like what Liz has said multiple times is, very often we come in and those care plan goals are not the patient's goals. So it's not really effective. It's not going to work out very well. And where that comes from is that kind of avoiding having a conversation with the person. And that's always the first step is, how can we talk to this person and find out what their goals are and how we can work together to get there. And we do hear from a lot of people that they just kind of say, like, I don't even know where to start. Like, I feel really uncomfortable. Coming back to the, lack of education and information, that's understandable. We can't be experts in everything. And because of that, a lot of that stigma that we have in our society, we kind of come into those things with some loaded ideas. So we have been working on a document, again, to kind of support people that are working on care plans and trying to do that collaborative work. And so it has some of these sort of even conversation prompts. And the thing that I kind of just want to point out about this is, obviously, this is, well, it's probably my wording, something that I would say that I feel pretty comfortable saying, but it's not like, not everyone's going to want to say those things exactly the same way. But I think it also, we can read through that and see how that trauma and violence informed lens is coming through, that we're, really trying to align ourselves with someone and focus on shared goals and really take that strength-based approach with someone.
I'll briefly talk about our addiction medicine consult team. So like I said, they follow up to a quarter of all inpatients at St. Paul's. Up until about a year ago, we had at St. Paul's 3 physicians, 2 social workers. We have 1 for the inpatient medical units and another 1 for inpatient mental health, and 1 nurse educator for substance use across all of PHC. So we're quite a busy service. So we're excited to say that this week we've added a 4th physician to our team. And again, this is just at St. Paul's. We also have a consultant, an AMC consultant, who's available at Mount St. Joseph's. That's also sometimes people aren't aware. But physicians can contact him Monday to Friday by phone. We also, in the last year, have added a number of different roles to our team. So we're very lucky. We have a pharmacy specialist here with our team at St. Paul's, who's super great. We also have 2 AMCT liaison nurses. And so this position was designed to support nurses on the unit. So say someone's never given, IV fentanyl before, or perhaps they're going to have a conversation with the patient, like, can you walk me through that? And so that's been super useful. They can also help review nursing care plans or interdisciplinary care plans. So they're here now 7 days a week. That's Danielle and Anton. And we've opened up, or perhaps it's this week, that we'll offer this to nurses at MSJ. They can give this nurse a call if they have any questions on the weekends. And we also have a peer navigator who works with our team in the inpatient side, and her name's Karen. And if you're interested to learn more about that role, let us know. But she's available to support patients followed by AMCT as well, and she can be consulted through the AMCT liaison nurse. So we're so grateful, and this has been a long time coming to get some more resources. So we're super lucky and love the team that we work with.
One of the other resources that Providence Healthcare has that we're always happy to talk about is the Indigenous Wellness Liaisons. So these are internal specialized consultation team who support self-identified Indigenous patients and families, and they facilitate access to cultural practices, traditional medicines, ceremony, and also access to the All Nations Sacred Space in the Broward Building. And then they can also facilitate access to connection to community supports like elders. So the Indigenous Wellness Liaisons are Indigenous and they have social work backgrounds, but they are operating in a non-clinical role. They support any self-identified Indigenous patient or families with the day-to-day healthcare navigation and supports, which includes discharge planning and culturally safe supports in the complaints process. And they also provide support to healthcare professionals in embedding principles of cultural safety and cultural humility into patient care. So their goal is to help ensure culturally safe experiences for Indigenous patients and families accessing services at Providence Healthcare.
And they're available, they'll go to all sites.
Yeah. And I'm very pleased now to hand over the microphone to Brian. As we mentioned, he is a peer navigator who works at the Rapid Access Addiction Clinic. He's bringing his knowledge and experience to the Urban Health Program. And we're so grateful for all the work he does supporting the RAC Clinic, clients, and staff, and for having him join us today.
Thank you. Thank you very much. I'm going to talk about some negative and positive experiences that I've gone through at the hospital here. Not just on one given day, but over multiple. I just kind of bulleted a few things out. I mean, there's many more, but for the sake of time, I'll just kind of go through each one here. So some negative interactions I've had. A lot of it concerned like body language, things like eye rolling, or if I'm asking for something, a sigh, like really, do you have to ask me for this? Threats of removal from the hospital, being impatient with me, being rough with me. I was asked to give blood one time, and I was so dehydrated and so skinny. Like I'm a pretty big guy now. I was about 160 pounds, and that's bone rack for me. The guy just wouldn't say, he wouldn't take no for an answer. So he's spearing my hand, and I'm asking him to stop. And that was a real mess and a very, very bad experience. She had mentioned audible stuff. I had a nurse call me that crabby junkie. I overheard her say that. I was already not wanting to stay at the hospital, and actually a police officer that I was in with that day said that he would sit with me and make sure that none of the nurses were going to be hassling me, because I didn't really want to go, but I was really, really sick. So not being able to access meds, I had an active script for Dilaudid. And I had just kind of moved back down to the city, not far from here either. And I was having trouble finding a doctor in the area. And I came to the ED, and they just told me to bugger off, which I found kind of strange. If I was drug seeking, I could understand, but that wasn't the behavior. So withholding things like water, juice, food. There's been instances where I've come in undernourished and have asked for something to drink, something to eat, and blatantly been told, no, we don't have anything, only to see somebody a little more clean cut, a little more, well, maybe not so street than me, get something, which was rather disappointing. There was always an assumption that I was in for drugs. I came in one time with a persistent rib injury, and over a period of a number of times I just got the glares, and they would make me wait like these obscene amount of times. I think that they thought that I was looking for drugs. I could tell just by the way they were looking at me and talking about me that they figured that's what I was here for. There were nurses that would not follow a doctor's order for drugs for me. I had a super high tolerance, and the nurse said that as my understanding was, and I don't know nurse policy all that well, is that there was only a certain amount that nurses had to give. And this particular night, all the nurses kind of banded together and said that they were not going to give me over that amount, which I required far more. To put it into perspective, I think it was 30 milligrams of liquid Dilaudid. I mean, at one point in the hospital, I was getting about 160. So you kind of see the difference. Well, on to the good. When I was on floor 10, I felt that the doctors and nurses up there, they knew my immediate needs, and the main immediate need for me was to get as high up on an OAT treatment. So they had me up on Cadian as quickly as possible, which is alleviating the need for me to walk out of the hospital, which I had done so many times. I was in there for endocarditis, and this is over the period of a year. I think I spent about a total of 5 months, maybe something like that, over the period of a year. I got to meet Naomi and Danielle and Kinnan and all those lovely ladies that made me feel really welcome. There was a particular nurse that shared her story that was similar to mine up there, which meant a lot to me. I felt that she was showing me some vulnerability and trust on her part, and it made a deep impact. She was actually directly responsible for me going to treatment. I was actually walking out the door that day, and she found me in the tent downstairs shooting up, which pushed back my entrance to treatment for a week. But as nice as the hospital is, they let me stay the extra week in a bed upstairs. And they didn't have to do that. All the beds were filled down at TCC, so they juggled it and allowed me to stay. They spoke to me with dignity and no judgment. I felt really happy and secure upstairs. It was a big difference between that and the ED. Eventually, I got quite comfortable. So comfortable that they actually let me bring in a widescreen TV in my Xbox One, which was nice to have that little comfort of home. I was just off the street and I didn't have anything. I knew I was going to be in there for a while, so I went and picked up my disability check one day and lugged it all back to the hospital. They gave me encouragement to stay. I was starting to get into a habit of skipping my antibiotics, and I had it 3 times a day, 6 weeks. And they drove home the point that if I wasn't going to do it, that eventually I was going to get into some trouble and probably die. I was quite sick when I came in, so I get them all. I felt like the doctors and nurses took an interest in my situation, and I didn't feel like I was like a number or just another name on a list, which was really meaningful. So that's about all I've got for the negatives and positives. That's just in the interest of time. I could go longer. I became a peer, and I just put this down in bullet points too. In hospital, endocarditis, 2019, 3 times. Finally got it cleared up by August 25th. They let me stay in the hospital until September 3rd. I went to Emerge treatment for 3 months. December 3rd, I was out. I went into second stage recovery at Belkin, and that went until June 23rd. The stop team that I was working with at the time had put my name in at McLaren Housing. So it was a nice surprise to find out that I got a place there, because it's a really nice building and they have unbelievably awesome staff. To go from the street to treatment to secondary to McLaren was almost a little too unbelievable. Like, I mean, it's quite hard to find a studio suite in the West End for $375 a month. So yeah, a little fortunate on that end. The stop team had actually said that they were really pleased to see how fast I was progressing. I've been clean ever since I went into treatment. So they had suggested that I apply for the peer navigator job at AIDS Vancouver, because I'm HIV positive. So it just seems like a natural role. I applied for it. I didn't hear back in about 5 weeks, and I was actually hoping to hear from them sooner. I was a little angry that I didn't get a call back, but they called, and Glenn brought me in for an interview, and I've been working at the RAC clinic since April of last year. And yeah, here I am now working with these two lovely ladies. There we go.
Oh, this is awesome. Thank you so much for sharing.
No problem. Should I just sit back down?
Well, I think,
Any questions?
yeah. What do you want to run through your last slide and then we can, no.
Oh, well, I can just say, and Brian just kind of touched on some of these things, but I think when we're working with people, we just might need to redefine what we consider success. So I'm talking about things like perhaps somebody is declining vitals or, whatever, but they're getting all their doses of antibiotics. Like, I would consider that like successful. Being flexible, like as Naomi mentioned about this, perhaps unwritten 6-hour rule kind of thing. It's unfortunate for telling people they need to come back within 6 hours, what they're not to use, and then they use benzos and they're quite sedated. Like, we need to kind of be flexible around that. And community teams can actually be really helpful at helping bring people back into services and celebrating successes, no matter how small, keeping in mind patients' goals. So I'm thinking things like maybe someone's end goal might be abstinent, but this week they've reduced their use by this. Like, that's a success, right? And make sure that we celebrate those successes, no matter how small, because that can be really meaningful for people.
Yeah, I think we have a few minutes for any questions that people either in the room have, or Angela, let us know if it's online. Can they use Menti to ask a question? You can use Menti to ask a question. We do have a slide after this just with evaluation, so hopefully you stick around for that. But yeah, if there's any questions at all, I know we covered a lot of material.
Go for it.
First of all, I just want to say thank you to all of you. Just a quick question regarding
Oh, when you talk about us at the Zoom, we didn't know. That's like,
hello?
So you can talk now and they'll hear you on.
Oh, I can talk now.
Yeah.
Do I have to talk into this thing?
Yes.
Okay.
Sorry.
Thanks
I
for
didn't
that.
tell you.
Yeah, I just wanted to say thank you so much for your presentation, for your thoughtfulness. And Brian, thank you so much for sharing your own experience and for opening up with your vulnerability. I think that really drove this whole presentation home today. So I really appreciate that.
I'm happy to hear that. Thank you.
Yeah. One thing I just wanted to ask, just a couple of pieces, actually. One of them on language, you kind of referenced 2 pieces of terminology. So people who use drugs, as well as persons with substance use disorder. So I'm recognizing the people first terminology, absolutely. But I guess I wonder about like, what's the current thinking on this? Like, I think people who use drugs might be less of a binary than people with a substance use disorder, which kind of you either land in or you don't, and it can be potentially pathologizing. I understand the utility of it, but it's something that I think about. And then I guess the other comment question I have is, Providence, I think, has done a tremendous job in advancing harm reduction and support for people who use drugs at many of our sites. One area that I think needs work is long-term care. And I think I've engaged you guys years ago to come when Lingera was bringing the OAT to long-term care program that was kind of, I don't know if it still exists but just hoping that we can maybe get a little bit more movement. I think one of the things that I see is people who can't go to long-term care because of substance use, and it's really problematic.
Yes.
So
Yeah, that was a big issue for us on 10C and 8A, where we would have nowhere to send people. Yeah, and yeah, that was really problematic for sure. I don't know how much we can address that one very quickly, but definitely we can connect with you around providing education for staff. Certainly, yes, that would be lovely. Do you want to talk?
Yeah, I mean, I think like you mentioned, like people who use drugs can be binary. So there's a whole spectrum of when we talk about substance use, but only some people will meet the criteria for substance use and substance use disorder. So yeah, like when we talk about it, and I know I use people who use drugs. That's kind of like the more general thing, but in healthcare, we would say people with substance use disorder. But having said that, people will come in who use substances, who don't necessarily have a substance use disorder, but we should treat them and apply these same principles like across the board. But just like more generally, that's for like a more general term, whereas a substance use disorder is technical and there are specific diagnostic criteria for that, but that's a very good point. But I think people who use drugs, like I use that, I try to go away from illicit. Illicit is a word that I don't use, especially with decriminalization on the horizon, like at least a start towards that. But yeah, person first for sure. But yeah, there's lots of terms, but yeah.
When I'm charting, I even tend to use substances and then specify, like, I don't know, because I'm always I'm always cognizant that the patient basically can go back to their chart at that point. Or other.
Yeah. I see some of the questions on Menti. I think the quick answer for the 2 sites offering safe smoking spaces are tents that are in the downtown east side.
And you can find out where those are on Vancouver Coastal Health. You can search Vancouver Coastal Health overdose prevention, and there's that list of sites. The OPS in hospital is another question. Is it only for patients? It is designed for patients. However, we won't turn people away, particularly if there's a family member or support person for them, for that patient. We won't turn people away. However, we also don't we're not like a community OPS kind of thing. I don't know how much we're running out of time, but I can see these questions. We're going to leave our emails, like reach out to us at any time. We're happy to answer questions. We are happy to provide more education to whatever area, but I'll let you go ahead.
Oh, sure. Thank you so much. I just wanted to reiterate what Jenny had said. Thank you to all 3 of you for some really valuable information and some shared experience.